So today we're going to be going over drug-assisted innovation and rapid sequence innovation. We'll talk about the differences between the two. Drug-assisted innovation includes RSI. It's a little bit more of a blanket term versus rapid sequence innovation is talking about a lot more specific type of concept. In class, if we want to try and differentiate the two, we're going to talk about drug-assisted innovation being basically what we do here in Las Vegas, and that we're using an induction agent and that we're going to be inducting a patient in order to intubate our patient. Rapid sequence intubation, we're going to be more looking at the using paralytics, and that's a bit more of a specific term having to do with paralytics. It also has to do with roughly how quickly we do it. You might also see at some places it described described as rapid sequence induction. Induction and innovation, kind of the same process, and we'll go over a little bit of that as we hit those slides. So that's what we're going to be going over today. RSI involves the administration of a potent sedative as well as a paralytic, and the paralytic is a key difference here between the two of them, in the sense that RSI has paralytics involved, where DAI is just, as far as we're going to be concerned, just the sedation for induction agent. So with that being said, the rest of RSI, it uses a neuromuscular blocking agent, aka a paralytic. At the same time, more or less, we typically want to give our sedative prior. Not a whole lot time, very much sooner. There is a third one that you might see mentioned or talked about, and that is DSI. So it's delayed sequence intubation. It's the same thing. I'm not going to go into too much in class because I don't want to try and add an extra layer and confusion between DAI and DSI. So, and all it is giving your induction agent, your sedative earlier, and then waiting a few minutes prior to giving your intubation itself. Your paralytic. Whereas RSI, we're going to go with paralytic. So I mention it now. Don't worry about it very much. And then overall, it's a thing. We're not going to spend too much time on that. Being said, rapid sequence intubation, we're giving our paralytic and our sedative or induction agents, and I'm going to clarify that statement here in a couple minutes. But here, at roughly the same time, typically sedative, and then our paralyzing agent, and then go ahead and intubate. And we're typically trying to do it in a pretty quick fashion. RSI, by definition, is going to be usually less than a minute. But all that still being said, it's not indicated for patients in cardiac arrest or for deeply comatose patients when immediate intubation is required, aka our crash airway. So we talk about a couple of our different airway patients. Crash airway being that patient that the patient just crashed, is about to code. We're getting an intubation as soon as possible. We're not worried about using any type of medications to help us with the intubation. We're just trying to get the intubation done ASAP. And then RSI and DAI are our other ones. So DAI is a term used for any use of medications that facilitate endotracheal intubation with or without neuromuscular blocking agents. If you describe in class that you want to RSI or that you want to use DAI and you talk about using a paralytic, that is acceptable, absolutely. Definitely no hit points on that. And there might be a test question somewhere where they talk about a paralytic being used for DAI, and that is appropriate. But just for us, when we're talking about it, for differentiating between the two, to try and reduce any confusion, we'll just roughly talk about DAI using more just our induction agents, even though it can be used for both, and we still can do that in class, not a big issue. But we're just using an induction agent to produce induce our patient into amnesia and anesthesia in order for us to do our invasive intubation procedure. So with that being said, we're going to be using that here, and we'll talk about our different agents and everything. And that's basically what all this lecture is talking about, is all the medications that are involved with the intubation procedure and how we can go about doing this well. So that being said, next we will continue on here in just a second. So much like anything that I've, especially in some of the other, particularly the airway classes, but many of the classes that when I've brought up different innovations and just in general, preparation is huge. And then if we look at the rest of the piece, so our preparation, our pre-oxygenation, done simultaneously while we're preparing things. So we're going to get we're going to start getting the pre-oxygenation done, and if whether that includes using a BVM non-rebreather, high flow nasal cannula, whatever we're kind of rolling with there, we're going to work on that pre-oxygenation. Ideally, we'd like to pre-oxygenate our patient, have someone else, if they need a bag valve masking, ventilating the patient, while we're then getting our airway roll. Hopefully, if we have, typically that can be done by an intermediate or a basic, and then the other part is the other medic on scene hopefully will be dealing with the paralytics and or induction agents, while we on the airway are preparing our airway roll, getting all of our backup things, making sure everything's done. So then we're going to talk about our pre-treatments, any medications we need getting on board. Sometimes we'll talk about using fentanyl for certain patient populations or conditions as a pre-treatment as well as post. I haven't used this a ton. I have used it. It seems to be work, but it's not anything that I find critical. But it can help reduce blood pressure spikes and or blunting some other things that the physiological changes when we stick a blade and tube in someone's mouth. So that being said, just doing all of our pre-treatment medications, fluid boluses, getting push-dose pressors, all those things, and we'll get into some of the details of those here in just a moment or throughout this lecture. If you're unfamiliar or haven't heard of the push-dose pressors or have much experience with them, we'll get onto those here shortly. Once all those are done, we have our sedative on board, we have everything ready, then we're going to go ahead and get our paralytic on board. That paralytic is there, and we'll go through all the details of the paralytic, the medications, the two main that we use in the pre-hospital environment, and really that are used for induction in general, and kind of talk about that here. And then our post, we're going to do our placement, putting the tube in the hole where it needs to go. The most important part of all of this, but the more that we are prepared, the easier that the placement typically becomes, or at least looks. Even if we have a very difficult airway, if we prepare our patient as best we can, it'll improve our odds and reduce our time that we're messing around trying to do other things. And that's one of the biggest differences you see between an experienced innovator versus a brand new one, is just a lot of that preparation, the amount of times in there. Yes, there's some skill and some other things in there, but it's really not skill. One of the biggest things that really makes you look good and makes it look like you know what you're doing is just preparing things. And you can start preparing things while you're still pre-oxygenating your patient, getting everything set up that we can with positioning, everything like that. And then we're gonna go over post-intubation management, and in particular we'll definitely talk about sedation and our post-intubation sedation packages, what we can do both locally in Southern Nevada Health District as well as some decent some national standards. I might make mention of a couple of the medications that could be used. And then if the RSI is unsuccessful, the airway should be managed by other means. If BLS airway can be used, we will use and is working, we will ventilate then with BSI or BLS airways, so OPA and BVM. If basic airway maneuvers are not working, BLS is not working, then we'll move to a supraglottic isn't working, then we'll go to cricothyrotomy. When we're having a failure to intubate, failure to oxygenate, failure to ventilate type situation, that's going to be a little bit more for the difficult airway lecture, which should also be available, or it'll be usually the following week after our DAI RSI lecture. So induction agent, these are some pretty I know this is pretty bland, but many times when I read directly off the slide, it's typically because it's a definition, and this is definitions I pulled from, I believe Webster's or one of the dictionaries, just to get an idea when I kind of talk about a couple of these different ones to help try and differentiate some of these. And what we need to be kind of looking out for. So induction is a process of bringing about something. Talk about inducing a patient. We're bringing about something, and that is a state of amnesia, so we can stick a tube in their throat hole, aka the trachea, right? So that's kind of what. So the induction is the bringing about of something. Sedation is the administering of a sedative drug to produce a calm of sleep. We use sedative 2 times in the intubation phase. We'll talk about in the induction phase and then in the sedation phase. And post-intubation sedation more specifically. I will try and differentiate these a couple times. Sometimes the wording just it fits for both, or we'll talk about using a sedative agent in order to induce our patient. But I do try to clarify as much as possible that when we are when we're doing induction, we're doing it to be able to intubate our patient, and that's kind of what that induction idea is versus our post-intubation sedation, which is typically a lighter sedation, and we'll go over that here shortly. Paralysis is the loss of ability to move in part or most of the body, typically due to illness, poison, or injury. And in this case, the patient is being paralyzed due to a poison, rocuronium or succinylcholine, our 2 blockade agents are poisons, as are most medications depending on various doses, but in general it's kind of considered poison. But we're paralyzing our patient in order to be able to intubate our patient easier and safer. And we'll talk about the specifics of why RSI and paralytics are important, and I hope in some Nevada Health District we get it soon enough. And we'll kind of go about that. So, and then analgesia is the inability to feel pain. This is an important aspect that many times gets left out of consideration when both in intubation, but especially in post-intubation sedation. We tend to just think about trying to keep our patients snowed out, sedated, unconscious, but never really address pain. Very few of our sedatives, and any of the actual true sedatives that's not ketamine, just more of a dissociative, actually produce analgesia. They don't actually address the pain involved. Do they cause the patient not to remember? Yes, but many times patients will still have a bad memory of some type. They don't necessarily remember what happened, but they're in pain, and they're also still having a stress response, which is an important aspect when we talk about our patient and how we're trying to treat them and help them out. And we don't typically always really want that stress response there. We want to try and make this as painless as we can, and we'll kind of talk about some of these. So while the sedation, anesthesia, and general anesthesia are forms of anesthesia, sedation is a component of general anesthesia. They are a bit different, right? So sedation, when we talk about sedation, is typically talking about more of a lighter sedation. A general anesthesia is what happens when you go into surgery. It's what an anesthesiologist does by definition, right? They bring about this state of amnesia, of anesthesia. Patients under general anesthesia have a complete loss of consciousness. This means they will not hear or remember anything. If there's it says nothing about pain, and it's not necessarily their goal dealing with pain. So we'll get into analgesia a little bit more here coming up. In contrast, a state of being between very sleepy, being relaxed in consciousness, and yet not unconscious characterizes sedation. So it's just a little bit of just generally sedated versus general anesthesia. We're talking about this aspect of keeping the patients a little bit more lightly sedated post intubation, not for our intubation attempt in of itself. That we want them in anesthesia. The post intubation sedation, we want them in this lighter state of sedation. So we will tend to use a little bit lighter doses, and that reflects into the protocols. We don't necessarily want these in deeper states of sedation. If they're still in this deep sedation by the time we get them to the hospital, no biggie, good job. We got our tube, all the fun things. But we're looking at re-sedating our patient depending on what medication we use, such as like if we use etomidate, which has a much shorter half-life, then we're a little bit more we should be a little bit more aware of keeping our patient properly sedated. We'll talk about some different sedation scales and that are used in the hospital, and while they are practical and important for the field, some of them aren't, they don't cross right over because typically in the hospital there's not as much going on, there's not as much outside stimuli, they're not still in quite a shock, a sympathetic state because many times it's quieter, things like that. And so some of the sedation scales don't cross one-to-one from when we talk about hospital care to our care, but with that we'll generally try and keep in a general range of where we're talking about sedating, and I'll look at that in a moment. So when we talk about what state we're looking for with intubation, for the intubation procedure itself, we're looking for that general anesthetic state. Like what anesthesia does, you guys will see a bunch of them come OR time. And the idea there is to knock them completely unconscious. And we talk about our RAS score, the Richmond Agitation Assessment Score, or sedation score, sorry. We will kind of be a little bit more descriptive on the exact amount area that we kind of want them, but it's a moderate sedation or a deep sedation for the intubation procedure, and then afterwards it's more of that light sedation. So that being said, we will look at a couple of our other areas. So induction is using a pharmacological agent to induce general amnesia or deep sedation in order to intubate, as opposed to our sedation is using a pharmacological agent to keep a patient light to moderate sedation. So as far as what we're going to be talking about in class, this is the one where I just want you guys to think a little bit more along the lines and try and separate it, and it just for your guys' ability to try and differentiate in the little bit of the learning stages, the different states that we can be looking at trying to get our patients to and why. That's why we're going to be going over a bit more of this thing as we go through class, and we're going to continue to see some of this in general with our throughout the different scenarios and for the next while. And with all these patients, it'll be a thing throughout all medical school that we're going to talk about. When you're doing an intubation, what is your goal? What meds are you going to want to use? What med might be better? What might be worse? Things like that. So we'll get a little bit more deeper into that. Paralysis is a neurological blocking agent medication to facilitate emergency endotracheal intubation and mitigate unwanted physiological responses to laryngoscopy, intubation, and minimize the risk of aspiration. That last part, aspiration, is a vital part of why paralytics are important and why we want to use them. And we'll get into that when we hit the paralytics section. Sedation is used in airway management and ventilation to reduce anxiety, induce amnesia, and decrease the gag reflex. This is what we have in our system and why we use it. So we're going to talk about our sedative agents. I'll bring up when we hit the medication too, but ketamine, and I'll get a little more into, but it is a dissociative, not necessarily a sedative, because it doesn't really affect the GABA. Kind of hits a different pathway, and then DA instead. But as far as induction, calling it a sedative agent, even though it's technically dissociative. There's a lot of interesting technicalities in here. And even when we talk about etomidate, it has some unique properties that don't make it act like our standard benzos that just affect GABA. So that being possible indications for sedation include combative patients who require aggressive airway management, are too alert to tolerate intubation, and agitated trauma patients. Remember, sometimes, particularly head injuries, many times these patients are altered due to the head injury. Other times, patients are altered due to hypovolemia or hypoxia from trauma and or medical issues. And so sometimes we are intubating them for that reason. We don't see this as much on the ground, but it is definitely a consideration that we do, particularly if they have possible C-spine injuries and they are being transport, but they're being combative and they're trying to move around. By them being combative and moving around, they are putting themselves at risk due to being altered, and we need to sedate them for their own safety. So we'll talk about some of those. So when we talk about what sedatives are used for induction, and we're going to talk about a few of those. So it's induction, well, they can be used for sedation. These medications, the three primary induction agents in the pre-hospital setting are going to be our ketamine, etomidate, and Versed. 2 out of the 3 of those, ketamine and Versed, can be used for post-intubation sedation afterwards. Etomidate is not, and we'll go into why here in a few minutes. Induction agents are meant to put a patient into an anesthetic or deep sedative state to perform an extremely invasive procedure, aka an intubation. And intubation is very invasive and very painful, hence why we need to address pain when we get the opportunity to. Anesthesia means loss of sensation. Medicines that cause anesthesia are called anesthetics. Anesthetics are used during procedures to numb sensations and induce sleep. This prevents pain and discomfort and enables a wide range of medical procedures to be carried out. Our first one we're going to hit is ketamine. Ketamine induces a dissociative state resulting in sedation, amnesia, and analgesia. Its effects partially due to the non-competitive blockade of the NMDA receptors in the cortex and limbic systems. Ketamine is not a simple pathomimetic. However, it will cause the release of the body's catecholamine stores, epinephrine, norepinephrine stores, and which can produce hyperdynamic effects. However, the body catecholamine are depleted. Ketamine is technically an inodilator a bit, and it'll actually cause hypotension and vasodilation. We don't notice that. We just notice a spike in it in the majority of our patients. However, in our very catecholamine depleted patients, whether it be a trauma patient who's been taking like 30 minutes to extricate some other ones, and maybe they have this massive injury going on, or they don't have a ton of catecholamines already. They can be that our septic patients might be catecholamine depleted because they might have been sick for a while. There's a number of these patients where they might not have the ability to release some of those catecholamines if their body's already depleted of them. And so they will ketamine can cause our patients to become hypotensive. One interesting aspect of ketamine is that it has analgesic effects. It is able to bind to opiate receptor sites. It doesn't quite cause all the CNS depression that opiates will. It also causes them not to care very much. They get in a slightly dissociative state, or in the pain doses, and a complete dissociative state in our the dissociative doses as well. But analgesia is affected throughout, and it helps pain throughout, which makes it really useful for intubation. So then we don't have to necessarily look at addressing pain, although sometimes because it is it is synergistic with opiates, it does help us to give a little bit of fentanyl in there and watch our patient just mellow out after intubation, particularly if you had a little bit of a transport, like a 10-15 minute transport. Many times ketamine can be extremely useful, or if you gave ketamine, to give a little bit of fentanyl just to keep them a bit more relaxed. It has bronchodilation effects, which is ideal for patients with bronchoconstrictions. They're not entirely sure how this pathway works. There's some thoughts that it happens via the release of some of those body's natural catecholamines, and like epinephrine is a bronchodilator. However, there's a couple other theories as they've been trying to test and figure out how some of these medications work, that on why ketamine is effective as a bronchodilator. They do know it does work, and there is some interesting studies out about using ketamine as a way to deal with certain patients who might possibly be status asthmaticus or dealing with that. But when we talk about a reason to use a certain medication over one induction agent over another, if our patient is getting intubated due to COPD or asthma, where we normally use bronchoconstriction, bronchodilator medications, or they might already be on a duoneb, this might be the reason to go to ketamine versus etomidate. It is a myocardial depressant. However, the release of the catecholamines typically negate that purpose, and so we don't see those actions. And however, we can see them become hypotensive and bradycardic in the patients that are catecholamine depleted. It can cause hypersalivation, and pretty heavy hypersalivation. So have suction ready. Give it a little bit slower, and we'll reduce some of that hypersalivation, as well as we will lower the chances of laryngospasm and trismus. It has neuroprotective properties. On this one, it's another one of those ones, it can kind of raise the seizure threshold. It adds some extra protective properties in there. Overall, it's not an epileptic. It's not like benzos that will stop a seizure or anything like that. But if it's in head injured patient, we'll kind of give that. And that kind of brings up one of the last things that we'll talk about with ketamine as we go into it. In that ketamine, there was a study on ketamine, and many FTOs might not have been updated. So you might say, oh yeah, I want to use it for this patient. FTO might be like, no, we don't use it on head injured patients, and that is not this what all the studies and the new basically the standards of care are now. Ketamine is safe to give in head injured patients. There used to be the old study was talking about how they will deal with have an increased intracranial pressure, while the blood pressure you do have a transient blood pressure increase. Usually it goes away over 5 to 10 minutes, and it typically doesn't affect there's been no real the studies have shown that the effect is not anything to necessarily worry about. However, the areas that I would be more cautious with, because we have that increase in blood pressure and heart rate, especially the heart rate when they're not catecholamine depleted, is in our cardiac patients. Those patients that can't really deal with that very high heart rate. They may already be in a hyperdynamic state, SVT, VTAC with pulses, things like that, where we would still use an induction agent. That would probably be a patient that I might not want to use ketamine with, and etomidate all of a sudden becomes a better answer in that case. Etomidate is a very useful drug too, but in general, both of our traditional main medications, locally we now, Versed is also a primary induction medication. Although on the medical advisory board meeting from the health district, when they were talking about using it, moving Versed from a backup to a main induction medication, there's a lot of pushback. It has some other side effects we'll talk about, mainly vasodilation and hypotension. Our doses for ketamine are going to be 2 milligrams per kilogram of IV, 4 milligrams per kilogram of IM, and it lasts roughly 15 to 45 minutes, and I've seen it last both of those. Many times we do see that. I'd say decent average is somewhere between 25 to 30 is what I run into. And so one other interesting aspect when we talk about this medication, especially that we'll go with, tends to be very useful, is that what it correlates to as far as using it with our paralytics, and we'll kind of get into that here in a few minutes. Etomidate is a sedative hypnotic agent commonly used for rapid sequence induction. It's an imidazole compound that acts at the level of the reticular activating system to produce anesthesia. The reticular activating system is what produces consciousness for humans and people and animals too. But that's what brings about consciousness. So by affecting that and so in this statement, because I pulled this from your cards, they say it appears to depress central nervous system function via GABA. It does use the GABA system. It affects it in a couple different ways, makes the receptor sites more receptive to GABA. It actually agonizes the GABA. And so we activate GABA. Now, the biggest difference between GABA, which is what this medication does, as well as our benzos affect the GABA system. GABA, if you agonize or increase the use of GABA, it causes a state of depressed central nervous depression, consciousness. GABA is what you kind of use to go to sleep. It's what alcohol does. It's a depressant. It causes you to sleep. Your GABA system is one that slows things down, kind of like the parasympathetic system. The NMDA is a little bit different. NMDA kind of keeps us awake, that whole receptor site, and it kind of goes the opposite. And so GABA causes sedation by increasing, and these, as etomidate and Versed, hit GABA, causing sedation. How ketamine disassociates is it blocks the NMDA system, which keeps us conscious, awake, and alert, and it disassociates us by blocking that ability for the brain to kind of work. And so ketamine is interesting, and that ketamine is the only medication that we carry that affects NMDA, as opposed to all the rest, which affect GABA. And this comes into effect and where we can start looking and thinking about using medications if we're worried about if we want GABA to be used, or if we want both sometimes. And that's what, and certain patients, like alcoholics, especially patients who are heavy alcoholics, all of a sudden they will burn through GABA more because they have more GABA receptors. They're used to processing GABA more, and so it takes more for GABA to take effect, as well as it lasts a shorter amount of time. And so in the ICU, when they have a severe alcoholic patient, there's a few other ones where they'll have this increased burning through due to GABA, and that they'll combine both ketamine and like propofol, ketamine and Versed, and like in the case of ketamine and propofol, they call it ketofol, and it's used in that because it hits both the NMDA receptor sites as well as our GABA receptor sites. So it's commonly used because of its ability to maintain stable hemodynamic. It's thought to maintain hemodynamics through simultaneous stimulation of the alpha-2 beta adrenal receptors. And so this is why ketamine and etomidate are used both in induction as the primary agents most of the time, because they are both hemodynamically stable. They both can cause an increase or decrease in blood pressures, but on average, it's pretty hemodynamically stable. And as well as they don't really affect the respiratory drive either way. They can, but they typically on your normal call they won't. Where else do we have in that? It's just, and they're really useful versus Versed has some more things that we're a bit more worried about. So gonna move on from there. So it causes, so these are some of the things that it can cause: is elevated or decreased blood pressure, apnea, laryngospasm, tachypnea, bradycardia. Once again, we're seeing both sides of these, right? Of tachypnea, bradycardia, hypotension, and hypertension. Hypoventilation, myoclonia, adrenal cortical insufficiency. This is a big reason in the hypoaldosteronism, in the sense that it causes a suppression of the adrenal glands and this insufficiency, and this is a very common issue with this. And so this is a important thing to think about. In general, when we talk about people in their shock states, our adrenal glands, they release our catecholamines, epinephrine, norepinephrine, as well as they release our corticosteroids and basically help us deal with being in a shock state with our sympathetic response. When we have adrenal suppression, we're now not able to, our body doesn't have the natural ability to deal with this state. So in case, and we look at most of our patient populations, most shock states we're able to fix in the ambulance or the ER, most of the time in the ER. But like if we talk about hypovolemic shock, especially with hemorrhagic shock, we can fix that with blood. Once we fix that and they go through the surgery, while there's still a lot of healing process and things like that, we fix the immediate reason of why they're in shock. We talk about neuroshock, they have adrenal glands at work, but there's just a disconnection between the brain and the adrenal glands, so there's no release of them, but we'll talk about that a little bit more when we get to trauma. And then we have anaphylaxis, which we can deal immediately with epinephrine, and we fix that shock state typically. However, one shock state, septic shock, which is distributive shock, and it causes vasodilation throughout because due to infection. This usually takes multiple days to multiple weeks to try and help. If we use etomidate in this sepsis patient, we can cause adrenal suppression, which then can cause the body to have an inability to really deal with this shock state. While we can give pressors and exogenous steroids via IV, things like that, corticosteroids, that the issue then becomes, though, that we suppress the patient's body's natural ability to respond, and they have poorer outcomes. So in the case of septic shock, we probably want to use something like ketamine a little bit more because we're not suppressing those adrenal glands. So, and intensivists, so doctors from the ICU, will avoid etomidate in the critically ill. That's not 100% across the board, but those are times that we'll look at avoiding of etomidate and maybe choosing etomidate over, or ketamine over etomidate for a specific reason. So sometimes it's kind of provider's choice, preference, number of small side effects, and there's other times, like in the case of bronchoconstriction or sepsis, that ketamine becomes the better answer. And other times etomidate's a better answer, and we'll talk about those in like neurodeficit type patients because we'll talk about it here in a little bit. So And this is just further talking about what I was just saying. Etomidate should not be used in the setting of sepsis or adrenal insufficiency. So if they have adrenal gland issues, we should not be using it. It is extensively metabolized in the liver, so caution should be used when administering etomidate to patients with hepatic diseases. It should not be used if there's a known drug allergy to that medication. So cool. Etomidate has a fast onset and short duration, typically 1 minute onset and lasts 6 to 7 minutes. When we look at our paralytics, you're going to see a couple reason why many people use a couple medications together. So this lasts only 6 to 7 minutes. That's a benefit sometimes, particularly if they're in a very acidic state and we have a hard time trying to match their EtCO2 to what their body currently needs. The patient's body is typically better at dealing with increasing respiratory rate and dealing with pH issues better than we are via EtCO2. We can. We're just not going to be quite as effective at it as the chemoreceptors within the body. So sometimes it's good to be able to allow the body to take back over, especially in the case like DKA, the diabetic ketoacidosis, and sepsis. So there's a benefit of sepsis here if they're not necessarily septic shock, but general just infection because if they're in an acidotic state. But we know probably don't still want to do sepsis for that reason. But if they're in a very deep acidotic state, metabolic acidotic state, that we would want to use etomidate possibly instead, or in head injury. So the neurologist can get a good idea of what their neurological condition is, assess and then reassess after interventions, things like that. So there's some reasons to give etomidate in general, and then we'll see when we bring up the paralytics, we'll talk about those as well. Etomidate has no analgesic effects. It does not affect pain at all. Sometimes etomidate and fentanyl are great both drugs to give in the case of intubation as well. Beware of short action, and if the second attempt is needed many times, the patient must be resedated. However, when we talk about that suppression of the adrenal glands, it happens with one dose, but it becomes extremely noticeable and causing systematic effects on redosing of etomidate. And so that second dose of etomidate is where most of that adrenal suppression comes on. A little bit comes on the first dose, so it's not always the worst to give. But on that second, if you have to reinduce, giving a second dose of etomidate is typically not an ideal thing to do. There was a study with etomidate where they were attempting to look at using etomidate as a post-intubation sedation type medication. So they got a drip of etomidate going on, and they had an increase in mortality by 70%. And so they cut the study short and don't use that anymore. It's not indicated for that situation for post-intubation sedation. So we talk about that. Etomidate is not a medication we use for post-intubation sedation. All right, our last medication we're going to talk about is Versed or any of the benzodiazepines. Versed tends to be very good for induction because it faster onset, shorter duration of action. It hits hard and fast. Ativan is a little bit slower onset and it lasts a lot longer. I like Versed and etomidate for post-intubation sedation, but I've anecdotally noticed many of my patients seem to have had more hemodynamic effects with Versed versus Ativan. We don't necessarily have to worry about that here, but sometimes that question comes up. Difference of the two, Valium or diazepam is useful as well. However, diazepam can many times only be given IV or PR, depending on where you're at, protocols, all those things. So, but we'll go to Versed. It can be administered via IO, IV, IM, or IN. Typically IVs very useful, IO is very useful, but with this and one of our paralytics, we can absolutely RSI a patient with no IV. And that'll be rocuronium as far as paralytics go. But its onset of action is about 2 minutes after IV injection with maximal effects occurring 5 to 10 minutes after. It's usually given over 2 minutes, so it has a little bit slower onset than our other two induction medications. It's very hemodynamic. It causes vasodilation. It decreases respiratory drive, which is neither here nor there because we're taking an airway. It is for other times for a combative patient, we have to worry about them not wanting to breathe anymore. But at this point, we're already taking over their respiratory drive, so it's not as big of an issue. Common adverse effects include hiccups, nausea, vomiting, coughing, headache, drowsing, pain during injection, and over sedation. We're not worried about over sedation. We're going for a deep sedation. In subset conditions that can reduce blood pressure, other agents should be considered, as with other medications, allergic actions can recur. Should not be used if there's a known allergy to benzodiazepines that can reduce blood pressure, so it's not recommended in settings of shock. Now you see why it's not necessarily recommended. All of the medications can cause this. Ketamine tends to be a lot safer, and it tends to be why many medics, particularly medics that have had ketamine available to their whole career, are a bit more comfortable with ketamine. Some of the medics in our system didn't get ketamine until they'd already been a medic for some years, and they're not as comfortable with it. Overall, though, I find ketamine to be very useful. It's typically my go-to. About probably 70% of the time, I end up using ketamine, so use it more often than not for intubation. Being said, that's just because it has some of those other effects, that's not saying you should develop. You're going to kind of work through your own processes and find what works better for certain situations. Kind of go on. All right, now we're going to talk about our paralytics. We have rocuronium and succinylcholine. Purpose of paralytics is to reduce the chance of aspiration by paralyzing gastric smooth muscle. There's a reason that's on top, because it's one of the most important things that we use it for. However, it also eases the intubation procedure by eliminating trismus, which is clenching the jaw, eliminates most cases of laryngospasm of the cord spasming shut, and some other issues with that, and then reduces instances of physiological responses through the intubation procedure, and having some of the parasympathetic stimulation going on. So paralytics are very useful, and anytime if you ever get a chance to use them in the OR, things like that, or if you're running a CCT rig, super useful. If you ever go, you're like, oh, this is great. The reason that we teach it here in this class is that Dr. Barnum, our medical director, who's part of the medical advisory board for the Southern Nevada Health District, almost every other MAB he brings up getting paralytics to the providers. Being that two of our primary induction agents, being both etomidate and ketamine, can cause trismus, which is a locking of the jaw. Our induction agents can cause that, and we have no way to really break it fantastically. You can put pressure on the angles of the mandible, kind of backed by the ear, put some there, and that can actually release some of that trismus. Give your induction medications a little bit slower, and it can help reduce the chances of trismus. But if it can now create a big issue, particularly so if we cause trismus and then we're not able to clear the airway, but the patient's jaws are locked shut and then they vomit, now we cause aspiration. This is why paralytics we should have paralytics with an induction agent. I'd rather have no induction agent for myself than induction without paralytics. But you could almost argue that having induction agents and causing a patient to trismus down and then vomit and aspirate is a bigger issue, depending on what's going on. So some reasons that it was taken away from the Southern Nevada Health District, they had it here at one time, particularly sucks, and we used to see mainly succinylcholine used most of the time. Rocuronium, but many times most of the time I'll either call it rock and succinylcholine sucks. Rock, sucks. That will go through this, and basically there for a while they were worried about the inability for a patient to, after giving paralytics, if we couldn't get an airway, how are they going to breathe? The thing is, in the pre-hospital environment and even in the emergency room, when we decide to take an airway, we're deciding it not because we are electively doing it for OR, surgery, something else. We are doing it because they have a failure to oxygenate or ventilate, and we need to facilitate our intubation. And so if we can't get because they're in the state, if we can't get a tube that way, we're either going to get an airway some way, somehow, whether that be BLS, supraglottic, or cricothyrotomy. We're going to get an airway, and if this patient, even if we didn't give any medications, mainly the goal of this would be they're going into respiratory failure and arrest, and we need to get an airway anyways. So the paralyzing agent just has a couple side effects depending on which one we use. One has a lot of side effects and one does not, and you can probably guess. All right, so we're going to start with rocuronium. Rocuronium is a non-depolarizing skeletal muscle relaxant. It works as a cholinergic receptor antagonist, inhibiting depolarization. So what it does is it goes in there and it antagonizes the cholinergic receptor sites in between the synaptic gap, or not in between the synaptic gap, but on the receptor sites after the synaptic gap, and causes muscles to have an inability. It just blocks them off, big old stop sign saying you cannot depolarize. We're stopping here. This only affects gastric smooth muscle, skeletal muscle, things like that does not affect cardiac muscle. So we're not going to give it to them and all of a sudden their heart stop. But rocuronium onset is about 1 to 2 minutes after IV administration. Duration of action is 30 to 60. You can see some variance in different areas if you're looking as far as its duration of action and onset. Typically, in general, what's interesting about paralytics, especially rocuronium, is that the higher dose that you give, the faster onset and the longer it lasts. Yes, if you give an extremely high dose, we would probably kill our patient at a certain one. But being said, giving a little bit on the heavy side of paralytics, even on the heavy side of our dose range. So our dose range 0.6 mg per kg to 1.2 mg per kg. You go from that 1 to 1.2 mg per kg, we're going to have that faster duration of onset as well as a little bit longer duration. So we'll get that 1 minute 30. Sometimes you can get it down to go even a little bit higher, like 1.5 to like 30 seconds, but you have this pretty rapid onset of paralyzation, and then it just lasts longer. It's minimally metabolized by the liver and may have longer duration of action in the setting of hepatic dysfunction. So if the liver's not working as well, it might last longer. It's not always that big of an issue. Rocking dose, I said 0.62, but 1 to 1.2 mg per kilogram. Very common dosage of 1 milligram per kilogram. If you give 1 milligram per kilogram in class, that will be not only acceptable, but that's a usually preferred one. So if we look at our doses, if you start, you'll also see the duration of action is very similar to ketamine, as is the dosing is also similar to ketamine, just half of it. So ketamine 2 mg per kg, rock 1 mg per kg. So if you figure out your dose for one, you just cut that in half, and that's your dose. So for ketamine, your half dose is going to be for rock. So if a 220-pound patient is 100 kilograms, our ketamine dosage will be 200 milligrams, and our rocuronium dose will be 100. Makes life easy, math good, love it. Duration around 30 minutes. The only there's like 2 side effects, and these are for all paralytics, but allergies and medications, and should be used in caution with patients in musculoskeletal disease, malnutrition, or hepatic impairment. Succinylcholine is a depolarizing muscle relaxant that combines cholinergic receptors at the motor end plate to produce depolarization, preventing neuromuscular transmission as long as it remains bound to the receptor site. So how succinylcholine works? Goes in between the synaptic, attaches to the cholinergic receptors, causes the entire muscle to depolarize, spasm out, fasciculate. Then it keeps it locked out, fasciculated. Some people like this because they can see when the patient's paralyzed. Or you can also do check with any type of paralytics is you rub like your knuckle a little bit right on the edge of their eyelash. If it flickers, they're not paralyzed yet. And if it doesn't, roughly paralyzed. They should be paralyzed. So, if nothing else, we won't have gag. Succinylcholine. It's some people like oh, I see the fasciculations. I know that they're paralyzed. Issue with that being, skeletal muscles are one of the biggest users of oxygen when in use. So if we already have a patient that's hypoxic and we're going to intubate them and we go ahead and give succinylcholine and they're oxygen starved, we now cause every skeletal muscle in their body to depolarize at more or less once, pretty quickly, and that uses a bunch of oxygen. So now we just lowered our oxygen reserve by deciding to use succinylcholine. Not as fantastic. During onset of action, some people are like, oh, it has a faster onset of action, 30 seconds to 1 minute. That 30 seconds between rocuronium and at a higher dose, it's almost negated completely. But if we go 30 extra seconds from sucks to rock, that's not, it might seem like a bit long as it's happening, but in reality, it's not a big, there's not a very big difference. When we talk about vecuronium or pancuronium, 2 other longer acting paralytics that are in the same category as rocuronium, they have a much longer onset of both onset of action and then duration of action. Duration of action is 8 to 10 minutes for succinylcholine. You'll notice that 8 to 10 is very close to 6 to 7 or 6 to 8 that you see at etomidate. This is another reason why many people would like to give succinylcholine and etomidate together, because they have a very similar duration of action. That's why many times in the ER you see that given. For most patients, succinylcholine can be a decent drug. That being said, here's all the side effects of succinylcholine. It can trigger a malignant hyperthermia in susceptible individuals. It can be a genetic issue that no one will necessarily know about, and they will have this hyperthermic reaction. and they need a reversal agent, otherwise they will die. There's reports of rhabdomyolysis with hyperkalemia, ventricular dysrhythmias, and death in children with undiagnosed skeletal muscle myopathies. It may cause intraocular pressure, increased intracranial pressure, flushing, hypotension, bronchoconstriction, and allergic reactions. In patients with personal or family history of malignant hyperthermia, patients with, and these are contraindications that we wouldn't want to give this to, and patients with skeletal myopathies like muscular dystrophy, Lou Gehrig's disease. In the acute phase following injury, major burns, multiple trauma, extensive denervation of skeletal muscles or upper motor neuron injury, succinylcholine can cause severe hyperkalemia, which may result in cardiac arrest, making it contraindicated in these settings. This is why I don't like sux and sux. It has so many side effects with no huge great benefit over rock, besides its short activeness. And then we add that aspect for our breathers, where all of a sudden, who are oxygen starved, that now have their oxygen affected. This is why sux. All right, so now we're going to talk about post-intubation sedation. Yes, we're talking about sedation agents, and we use sedation agents to produce induction, but now we're talking about post-intubation sedation. In the context of RSI, there can be confusion in the difference between sedation and induction. That's why I'm trying to separate the concepts here. If you have questions, keep asking. I will continue to try and add clarification and use certain terminology. It's not trying to be jerk, just trying to help you guys differentiate the two, because there's different doses and we're looking for different effects. Induction goal is to produce heavy sedation with anesthesia being the goal. Post-intubation sedation end goal is to keep the patient lightly to moderately sedated with analgesia and add analgesia as well. So we're going to talk about the Ridgeman Agitation Sedation Scale. Briefly brought it up a little bit earlier. Using the RAS score, clinicians can assess the level of sedation on patients. Typically, this is done in the ER or ICU especially. A partner of mine who's now has her doctorate as a nurse practitioner and works at Spring Valley. She did her doctoral project and used this RAS scale and did a bunch of research on trying to figure out how flight conditions how well we assess this. And there's very little evidence because pre-hospital is very poor at getting studies done. And so we get them, but it's kind of difficult. Number of issues are all involved with this, but it's hard to get some of these randomized studies. However, there's also a few extra things here when we talk about the RAS score. We are dealing in a much more higher stimulating environment. We're dealing with lights, sirens, bumps, motor, and we just intubated, all these things. And so it's harder to get an accurate RAS score with this, and some of them. And we cannot get a RAS score on a patient who is still paralyzed because they cannot have a reaction because they're paralyzed. So RAS score only applies to patients that are able to react, kind of like the GCS. So one important thing, every patient needs to be sedated or given sufficient analgesia for their current condition. So if we give etomidate and we give rock, etomidate has a 7-minute duration of action. After that, they are no longer sedated. Rocuronium has a 30-minute, 15 to 30-minute type duration of action. If this is the case, we are now having a patient with roughly 10 to 20 minutes of being paralyzed without being sedated. Paralyzation without sedation or analgesia is unacceptable and immoral. Don't do it. Now, the issue and the reason that some people are cautious, and it happens, you'll see it on your ER rotations almost every time a student or two sees this and they become a little bit upset and angry and no one else in the ER is noticing because the patient's not complaining because they're paralyzed, but they will get etomidate, they'll get rock, and then they'll be unconscious and with no sedation or analgesia on board. I would be irritated as well. I don't blame our patients. The only thing that we can do, you can try and ask the nurse if we think we should get some sedation on the board or the doc, because you notice some increase in heart rate, increase in blood pressure. They're more tachypnic. Oh, they won't be more tachypnic, but they'll have these dynamic changes and be like, hey, I noticed we didn't get any sedation or analgesia on. Do you guys normally do that here? You can try and bring it up without hopefully irritating them or like trying to. Nurses can be, especially in doctors more so, a little bit prideful and not think about it. But sometimes things are busy. They don't notice their patient is having these changes. And if they're already hypovolemic or in shock already, all of a sudden their blood pressure is 110, but it was 88. And it's just because they have such a sympathetic response right now, they will associate it with being in a shock state and not necessarily being in a pain state. We should try and address it with, if nothing else, with some mild fentanyl. Mild dose of fentanyl, like 25 mics to 50 mics, kind of depending on patient side. You can go much higher. Fentanyl is a very safe medication. We'll get into that in a bit for most types of states of shock, things like that, particularly in the intubated. We're not worried about the respiratory drive at that time. And it's very hemodynamically stable. It might take a little bit of that sympathetic tone down, but it doesn't cause hypotension in the same sense that morphine does, due to a couple things there, and we'll talk about that when we get to analgesia after this. So this is a Richmond Agitation Sedation Scale. We have the RAS score and then the description. So a +4 is a combative, violent, danger, and danger to staff. A +3 is pulls or removes tubes or catheter, is aggressive. +2 is frequent, non-purposeful movement. If they're on a ventilator, they're kind of breathing against the ventilator, fighting against the ventilator. +1's anxious, apprehensive, but not aggressive. A 0, alert and calm. A -1 awakens the voice, eye-opening, that lasts longer than 10 seconds. -2, light sedation, briefly awakens the voice, eye-opening, eye contact is less than 10 seconds. -3, moderate sedation, movement or eye-opening, no eye contact. -4, deep sedation, no response to voice but movement or eye-opening to physical stimulation. And -5 is unarousable, no response to voice or physical stimulation. Talk about RAS score in those different areas. When we talk about induction, when we're going to tube a person, we're giving that initial dose of etomidate or ketamine, or Versed. We're going for that -5. We're going deep anesthetic state. We don't want them arousable. For our post-intubation sedation, anywhere between -2 and -4. That is a lighter sedation. The reason that we want to do that is because the longer that they're in this deep sedative state, the longer their hospital stays end up being. So if they're in the hospital for a much longer time, they tend to also have, this also comes about along with the increased hospital time, is increased morbidity and mortality. So when we look at that, now this is, once again, this doesn't count if our patient is still in that post-induction phase right after our RSI or even just DAI with our drug-assisted intubation. That's not what we're looking for. We're talking about after they come out of that induction phase, when we move to a post-intubation sedation, then we're looking for that mild to moderate. You can go even do a -4 depending on the patient's state and how agitated they could have been. But the goal is roughly around a -3. That'd be a good one to go into. Depending on long flights, I'm good with a -2. Going through town, maybe we're driving back from a WAP and they're starting to wake up a little bit. Maybe their eyes open, but no one's there. Let's go ahead and do that. Let's go ahead and keep them in a little bit in that state. They start eye opening, grabbing tubes, grabbing IVs, doing other things, looking at you. It's really creepy when they have a tube and they wake up and look right at you. However, many patients in ICU that are still on a tube, are still intubated, maybe even on a vent, will be awake or in this very light -1 state. I'm not worried about you guys shouldn't necessarily be worried about being in that -1 state. That's an ICU problem, not an ER or emergent pre-hospital problem. But we can start thinking about a slightly lighter sedation phase versus our deep sedation that we use for induction. Sedative agents, if the goal of the patient is not paralyzed still, should be light to moderate sedation with a RAS score of -2, -3 with a maximum -4. If paralyzed, look for objective findings that indicate the patient is not sedated enough while paralyzed. Increased heart rate, increased blood pressure, eye movement sometimes. If they have that, you're not going to see that, like the pupils moving inside. You're going to be big ones because they're not going to have an increased respiratory rate because they're not going to be able to move their muscles. So try and look at sweating, things like that, that can be innervated via our nervous system, but our skeletal muscles won't respond. So sweating is activated via our sympathetic system only. All right, next we're going to look at our sedative agents. We got our benzos, which are lorazepam, diazepam, and midazolam. Midazolam is typically used. Lorazepam is really good for our post-intubation sedation, particularly for longer periods of time, but midazolam drips money too. All right, ketamine. Locally, ketamine can only be given once. We can give it a second time if we have orders. It is not a protocol deviation since you just have to, it's in the protocol to just call for orders. So all you're doing is following protocol, but you have to call for it first. Typically, it's not that big of, we typically don't need to due to our onset of action, our duration of action being as short as 15 minutes, but typically seen many times 30 minutes, 25 to 30 minutes is pretty average time across the board. 45 minutes, I've seen it in some patients. most of our transports are less than that. If you're coming back from something like Moapa, Indian Springs, things like that, and you're going to have a longer transport and your ketamine's wearing off, go ahead and do that. In flight, where we had pumps and CCT, what we do sometime, what I would typically do in our protocols were to give the amount that we use to induce, so 2 milligrams per kilogram over an hour. So if it was a 220-pound patient, which is 100 kilograms, that comes out to 200 milligrams of ketamine that I'd use for my induction agent. And then I would typically, because my vials came in 505 or 510, I would use that other 200 to mix up a drip and set that up for over an hour. But many times, due to longer duration effects, if it's used for induction, it's pretty adequate. Especially if you use a little bit of fentanyl just to help take off a little bit of that sympathetic tone, it works fantastic. Also, because ketamine's an analgesic, we don't necessarily have to worry about opiates, but sometimes like a 25 to 50 microgram dose of fentanyl does amazing to keep our patients sedated without adding any other post-sedation agents. If you use benzos, be aware of blood pressures and things like that. So next we're going to go into, and we don't use etomidate as a post-sedation due to that multi-dose issue that we talked about earlier. So analgesic agents, we have fentanyl, we have hydromorphine dilaudid, which is my favorite if I'm just doing a pure opiate to keep a patient that's already been intubated for a little bit under. It hits their opiate receptors, the pain receptors very well, and then it also causes it has that narcosedative effect that we see with morphine as well, not so much with fentanyl due to the different types of opiate receptor sites that are affected. You move or show. And so we'll talk about Dilaudid works amazing. There's a reason everyone wants that drug with a D, and it's because hydromorphine works fantastic, but especially in our post-intubation sedation patients. Morphine works really well, but the thing about morphine, it's kind of a dirty drug, so it causes histamine release from the mast cells, which causes vasodilation and leakage of some of the fluid in our vessels from outside the vessels inside, but it causes a lot of vasodilation due to the histamine release. So morphine causes vasodilation, hypotension. There's sometimes that's beneficial, like we talk about our cardiac patients. Maybe you tube a CHF patient or a acute MI who decompensates. Great drug. Patients who are really shocky, not a great drug. Fentanyl's a lot better. Fentanyl does not cause that vasodilation, that histamine release. It does reduce that sympathetic tone. It causes the sympathetic nervous system not to react and to act the same, or kind of just blunts that, and so it causes some of the increase in blood pressure and increase in heart rate to drop a little bit. So if they're already borderline, fentanyl might cause a slight drop in that. Be aware. We can try and fix that with a little bit of fluid, a little bit of push-those presses if we need to. Ketamine, it's the only non-opiate medication, even though it does hit our opiate receptor sites. It does not have many of the same side effects. It's not considered an opiate or anything like that, and it doesn't have it doesn't cause the central nervous depressant and the respiratory depression and hypotension that some of the other medications do. Due to using it most likely for induction or sedation, it's not a primary indication, especially using the pain dose. But if you decide to sedate them with it, you don't always need to add a pain medication on. But you're already broken up your narc box and you're already writing it in. It's not that hard, and you watch, especially with a little bit longer transport, how fentanyl works on that post-intubation analgesia. It's money. Fentanyl is a synthetic opiate that binds an opiate receptors, resulting in decreased pain. Intratracheal intubation results in sympathetic nervous stimulation that can cause significant increases in blood pressure. So when we reduce that sympathetic tone, sometimes that blood pressure will drop a little bit. Be aware if they already have very soft pressure. Fentanyl can be given before induction agents to reduce increases in blood pressure in patients with increased cranial pressure, in the case of head injuries, things like that, or in other clinical settings where rapid rise in blood pressure is undesirable. Its rapid onset and metabolism relative to other opiates make it a common choice. Fentanyl is very, very good for this. Fentanyl has minimal vasodilatory effect. There can be a minor drop in pressure due to the effect and blunting of the sympathetic tone and the pain relief itself. Typical dose 1 mic per kilogram. Sometimes you can see, you might see a doc give a lot higher. Many times the nurses are like, oh, you gave 100 mics, that's a ton. But particularly in intubation cases in the ICU, you see them up at like upwards of 2.5 mics per kilogram. My standard protocols of flight were 1 to 2.5. Onset's 1 to 2 minutes, duration 30 to 60 minutes. Man, that just rolls along with all the rest of our medications. Dilaudid, hydromorphone, decreases moderate to severe pain by binding opiate receptors in the central nervous system, depressing pain impulse transmission at the spinal cord level by interacting with opiate receptors. It has a more sedative effect than fentanyl and increased pain relief. Onset 5 to 10 minutes, a little bit longer. Onset duration 2 to 6 hours, a lot longer. Analgesic agents, morphine binds to opiate receptor sites. Older medications cause more. It's an older medication, causes more sedative effect than fentanyl, has that narco sedative effect. Sometimes that's nice. It releases anxiety. Sometimes that's a partial reason why I give it for, and why many people give it in the case like STEMIs or cardiac pain, because we're trying to reduce some of that anxiety, reduce some of that afterload, as well as the vasodilatory effects itself. Should be used when cardiovascular depression is tolerable or desired. So if the patient can tolerate it, or it is a want, like in that cardiac patient, it's fantastic. Onset 5 to 10 minutes, duration 2 to 6 hours. So even if there's times where I like morphine more, I want a little bit more snowing effect, and if I just want the pain effect, fentanyl's my answer. Ketamine primarily used as sedative, but it has analgesic properties. These analgesic properties are synergistic with opiates and opiates, increasing pain relieving capabilities. If the patient's being sedated and was injected with ketamine and ketamine still having effects, and then use your opiate and opiate pain medications are very synergistic, and it works very well. All right, push dose suppressors. Push dose suppressors have been found to help prevent peri-intubation arrest. Many times that when we go to tube a patient, we are causing them to code. They originally came about from push dose suppressors originally came about from anesthesiologists, then emergency room doctors began using them, followed by critical care and flight teams, and then kind of moving to pre-hospital. Now it is our only pressor that we have because they took away dopamine. So, and we have our two pressors are epinephrine and phenylephrine. We have both. Epinephrine is used more often, easier to make, and it has more desirable effects most of the time. There's times where phenylephrine is more appropriate, but typically epinephrine is a better answer. Not always. Many times, much like my probably more so, my ratio is probably like 80% epinephrine, 20% phenyl. I love Levo. We don't have Levo here, and Levo is not currently a push dose pressor. There are studies for it. Dosing is going to be pretty regular. Hopefully, we see that in a few years. Levo is fantastic. And we'll talk about some of these. Also, when we get into the shock chapter or in trauma, I will have a pretty deep shock and pressor lecture to help reiterate some of these things, as well as talk about pressors in the case of shock and when we can use which ones where. For now, we're just talking about push dose pressors in the case of RSI and induction. So, because there's this high chance of peri-intubation arrest during cardiac arrest in the peri-intubation phase, especially using RSI. RSI actually helps blunt some of these things too, but DAI in general, not just RSI. RSI actually helps blunt and help some of these. Patients with hypotension, borderline hypotension, have a chance of sudden drop of pressure due to numerous factors, including medication-induced hypotension, hypoxemia, direct manipulation of the airway, such as vagal nerve stimulation, increased interthoracic pressure with positive pressure ventilation, which causes a vagal stimulation, and we get that there too. So a number of reasons can cause the blood pressure to drop in our patient to start coding. If they're already borderline, they're going to code. So I've talked to many of our doctors, including Dr. Barnum and many ER docs. They are absolutely good with, if that pressure is borderline, say like 95/60, and you decide to go ahead and give a preemptive push dose pressor because their pressure is borderline and you're about to intubate them, like, yeah, that's safe. I've seen the doctors do it at Spring Valley. For one of our students was in there. I was doing a clinical site visit, watching him do it, and that blood pressure was up on there, and he says, go ahead and give push dose epi. Very common, very easy. When we talk about the doses, we're talking about 5 to 10 micrograms of IV push. It's in that 1 to 100,000 concentration. We talk the difference about how much is given in a push dose epinephrine versus when they code and they get a full milligram, which is 1,000 micrograms of epinephrine. A little bit of epi has short half-life, roughly about 5 to 10 minutes. We still have some effects up to 15, but usually after 3 to 6, we start seeing a decrease in its duration of action. Concentration is going to be 10 mics per ml, so 1 ml is a great dose. Go ahead and mark your syringe as push dose epi, and we'll go over this in lab, do all that practice. We'll have you guys make this throughout lab and get good practice with it. It is our push dose. It is a primary push dose pressor to use. It's a very useful pressor. Epinephrine is a simple pathomimetic catecholamine, has alpha, beta 1, and beta 2 effects, so it has positive inotropic, chronotropic, bronchodilation, and vasoconstriction. Inotropic, greater squeeze; chronotropic, faster heart rate; bronchodilation, fantastic; and vasoconstriction, increase our afterload and our preload. Primary uses in septic shock, hypotension with bradycardia, anaphylactic shock, cardiac arrest with ROS, neurogenic shock, almost all shocks. It's fantastic. Push dose phenylephrine. Phenylephrine works as a pure alpha agonist that causes arterial vasoconstriction, increases systematic vascular resistance. Phenylephrine has no direct chronotropic effect, which makes it an attractive option for patients who are hypotensive but very tachycardic. we have to look and realize whether a patient is tachycardic due to shock or they have some underlying issues. Most patients that we deal with can deal with a short, small acting increase in heart rate. That's not the big issue. The bigger issue is patients who the ones that I'm really concerned about are older patients or patients with cardiac conditions. If they have a heart that's barely pumping, ejection fraction like 20%, it's just struggling to go. And then all of a sudden we cause that increased afterload due to alpha effects and increased chronotropy. All of a sudden our heart has to work harder, increasing myocardial oxygen demand, which then causes further issues. So this is the time that phenylephrine might be more appropriate. There's some times we don't want to do, and it may induce baroreceptor-mediated reflex bradycardia due to rapid increases in blood pressure. So what happens? Phenylephrine has no beta receptors, pure alpha. So it causes all the squeeze on the blood vessels, causes the blood vessels to increase a bunch, causes our heart to have to pump harder in order to get the blood out. And when that happens, now the parasympathetic nervous system goes, yo, calm down, slow things down. However, parasympathetic system doesn't have a direct link to the blood vessels. So what you're going to get, but parasympathetic system does have a direct link via the vagus nerve down to the sinus node and the heart in general, and it'll try and slow everything down, and so we get this reflex bradycardia. Difference between phenylephrine and Levophed or norepinephrine, same drug, is that Levophed has a bit of beta. That beta counteracts basically that parasympathetic stimuli, and so all we get is pure alpha. That's all we see in the end is pure alpha, but that's because we have that little bit of beta counteracting that parasympathetic tone, which is why Levophed one of my favorite pressors. Hopefully we get it out here soon. If you ever heard Levophed, leave them dead, that is an old statement because people were doing dumb things with Levophed and causing patients to arrest. We'll get into it in shock. Push-dose phenylephrine has a rapid onset of about 1 minute, slightly longer duration of action compared to epinephrine of 10 to 20 minutes compared to 5 to 10. Typical dose range is 100 to 200 micrograms. So what you do, you take a 10 milligram, 1 ml of phenylephrine inject into a 100 cc bag of NS. Concentration in the bag is technically slightly off that, but close enough, of 100 micrograms to 1 ml in a bag. Draw out 10 cc's or 3 cc's even, and your dose is going to be 1 to 2 cc's or 100 to 200 micrograms of phenol. And go label it and use it. Love it. All right, phenylephrine alpha agonist only addresses pure vasoconstriction, primarily used when increased heart rate is not needed or warranted. Hypertension without bradycardia. So the case that we'd use is hypertension without bradycardia, septic shock, cardiac arrest with ROSC, hemorrhagic shock. Hypertension with tachycardia or heart disease or increased minor oxygen demand would be harmful, and that's primarily the one I'm mainly going to use phenylephrine for. You guys seen this? I'm working on getting you guys an extra card with some of this on this. We did give this handout in class. Hopefully, if you don't, come get one. All right, RSI goals. The goals of RSI in general, it includes the use of paralytics, includes the use of an induction agent with the goal of endotracheal intubation and hospital. It's indication for emergency endotracheal intubation for patients at high risk for pulmonary aspiration. RSI goals and how we're going to go about it. Rapid sequencing, we're choosing to use RSI. We're going to give our induction agent, quickly followed by our paralytic agent. Once the patient's intubated, are sedated and paralyzed, endotracheal intubation can be attempted. Once we get the intubation completed, we're going to confirm placement secure airway device, and look to sedation and pain management. Drug-assisted intubation. For the statement in class, yes, I know it can include paralytics, but just for the differentiation between the two, or we're just calling this DAI. So that top line doesn't matter quite as much. I kind of made this and altered just a few things. I was just trying to clarify because this question continues to come up. But in general, DAI for the purpose of the class doesn't necessarily include paralytics, but it doesn't necessarily include paralytics, but does include the use of an induction agent with the end goal of endotracheal intubation and follow-on sedation and analgesia. DAI, decisions given, induction agent given. Once a patient sedated, endotracheal intubation can be attempted after patient placement confirmation airway device secured. Let's go ahead and look to sedation and pain management. So we'll look through a couple of these. We talked about these kind of in class, but we have 55-year-old male initially, heart rate, our respiratory rate 32, it's now 8, blood pressure is 94/64, heart rate's 102, sinus tach, statin at 82, ETCO2 55. We can look at this patient, have a couple ideas what might be God. We can guess it could be COPD, possibly, could be CHF, maybe. But If anything, they are in respiratory failure because they initially were compensating with a respiratory rate of 32 and now it's 8. We're going to see that ETCO2 continue to rise and we need to fix it. We're going to intubate induction agents that we can look at trying to use. Ketamine and or etomidate would be appropriate for this patient. Paralytic rock, sedative, for post-intubation sedation. If we use ketamine, we can stick with just, hopefully it'll last longer. If we need to look at it, we can go to Versed if needed, or call for a follow-on order of ketamine. Analgesia, we have ketamine on board. We can look at fentanyl push-dose pressor. I would probably get a little bit of epi. Even if I don't start it, I'm going to pre-mix it and have it standby. So in case this patient the blood pressure starts to drop, we're going to go ahead and give that push-dose pressor. You would be safe to give this patient a push-dose pressor in this case with that blood pressure. All right, second case is a 32-year-old female, shortness of breath with wheezing. If we were to guess what would be causing this, most likely probably asthma. 35-year-old female could have COPD or it could be an anaphylactic reaction, but with wheezing, we at least know it is a bronchospasmic reactive airway disease. Should be. Initial heart rate 22, shallow, little air movement. Our blood pressure is 154/94, heart rate's 155, sinus tach, O2 sat 72%, ETCO2 20. They are hyperventilating, but there's not very much, and sometimes that lower ETCO2 might be because there's not a lot of gas exchange happening. Our induction agent, ketamine would probably be most appropriate because it has those bronchodilating effects. Paralytics, let's go ahead and rock. Hardly ever is succinylcholine a better answer. There's a few small ones, and if you guys will find one, but most of the time rock is almost always appropriate. Sedative agent after either most likely redose ketamine, but receptor work. Analgesia, a little bit of fentanyl on board, push-dose pressor. With wheezing, with a heart rate, I would think about phenylephrine, but she's 35 years old. Her heart most likely can deal with this increased heart rate. The increased sinus tach is most likely due to being in a hypoxic shock-like state. So let's go ahead and epinephrine will probably help with that bronchial dilation a little bit better. So let's go ahead and I would probably choose push-dose epi.